Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 38 and session number 2 since our partnership with the American College of Cardiology. It's my privilege to introduce to you one of the most illustrious cardiologists we know today, Dr. Valentin Fuster. He's the chairman of the Mount Sinai Heart Institute and the physician-in-chief at the Mount Sinai School of Medicine. Dr. Fuster, thank you so much for joining us. And what do you feel about the partnership with the American College of Cardiology, and how does it take our program further and your educational efforts forward?
I think it's exciting. We have been working with the American College of Cardiology in a number of educational programs in New York, in India, Brazil, San Francisco. And I feel very proud that Mount Sinai is now involved in this cooperation. I like the type of seminars that are being organized. Since the interventional field is becoming more and more complex. Elderly population, multi-vessel disease, I think judgment and new technology have to be up to date. And I think to have these seminars every third Tuesday for a period of maybe an hour or so, I think it's going to be quite educational, quite valuable, and quite exciting. I'm very proud to work with the American College of Cardiology.
Well, so much of this has happened under your guidance, and we thank you. From the last numbers we have, the program is now being watched by more than 5,000 cardiologists worldwide.
Welcome, worldwide audience.
Dr. Fuster, congratulations also for the wonderful ranking with the US World Report. Not only that, your cardiovascular lab continues to have the highest volume in the state, the lowest complications, the lowest in the appropriateness criteria. I'm sure you're very proud.
Yes, I'm very proud. I'm very proud. I believe there are two main reasons. One is this is Mount Sinai Heart Center. We are very integrated. This is a large group of people that feel happy to come to the institution every morning. We like each other, we trust each other, and I think one of the most outstanding groups, of course, is the one led by Dr. Sharma and Dr. Kinney. So I've been here many years and I feel more proud than ever.
That is fantastic to know. Tell us also about your own global health initiative, and this program in many ways ties exactly with that, no?
Well, yes, I think that today, because of communication, we know what is going on in the rest of the world and we cannot be passive. So we are taking an active role. One of my colleagues, Dr. Narula, is also working with me. We have 6 projects in the world, in different countries, from Kenya to Grenada, the island of Grenada, to Colombia. Projects that go from educating children into good habits with Sesame Street. Then we have programs in middle age, how people can help each other in correcting risk factors. I could take care of you, you could take care of me. And we have programs in the elderly, how to understand and maybe preventing degenerative brain disease, in which risk factors are very similar to those of cardiovascular disease. So we are working worldwide. We are very proud. We are expanding. And it's of interest that young people, fellows that are now in training, a large number of them, they would like to work in these global projects. This is changing. It is very exciting.
Wonderful. I wish you good luck with that, and thank you for stopping by, and thank you for all your support. Samin, let me take you back to your case now. You've got your hands full with another difficult case in an elderly patient.
And I really want to thank from our cath lab to Dr. Fuster, and clearly the mission, as Dr. Fuster mentioned, that he does global, the highest attended clinical cardiology conferences. In Brazil, we are like 2,000 plus people everywhere, and clearly with this, our mission tying together with a common theme from Mount Sinai Heart, that educate, educate, educate And we at our level in the intervention with myself and Anu and other our staff trying to teach all the tricks to get to the best results ever, and so that people can duplicate. And that's where the whole issue has been, the techniques, emphasis on the techniques, and that is clearly the part of the education will continue to grow with our ACC membership.
Fantastic, Samin. It's a pleasure having Dr. Fuster. Also, Neha, to our joiner people viewing us in mainland China. I hope you're able to get the Chinese simulcast. I have also received a lot of feedback from Dr. Spencer King's presentation and discussions last time, mainly about the AUC, which I'm sure we'll be speaking about today also. Samin, you're going to take us through the case?
Sure. This case actually, just to a little minor change, the case which we put on the web, the e-blast, last 1 week, actually that patient was 90-year-old, developed pneumonia, so that we have switched to another very appropriate case of the multi-vessel disease. This patient actually presented first time to Mount Sinai yesterday. If we can take it to the slide, with having a progressive class 3 angina, and one of our cardiologists did the stress echo, and patient has significant ST segment depression. We stopped the test and came for cath, and we are going to show that catheterization, which is multi-vessel, 3-vessel disease and normal ejection fraction. Patient has history of diabetes and family history, hyperlipidemia, on a good medical therapy, and actually we got hemoglobin A1C today of 7 and LDL of 80 plus. Clearly, so the patient has been well managed, and now Anu will take us through with the angiogram of this case. And the question is what to do. Patient with a multi-vessel disease, diabetic. I would say 2 years ago, this patient would have fit into the criteria of the freedom trial, inclusion exclusion point of view, and but the trial, as you know, it's in the final phases in terms of the data adjudication, and will be presented by Dr. Fuster with the PI of the freedom in AHA. Now, Anu, just the angiogram.
You can see the left vein is actually non-obstructive. Prox LAD has mild, less than 30% significant disease in the distal circ, and I would say moderate to small size LPL. The large high lateral slash OM is free of disease. So in the cranial view, you can see the 95% calcific mid LAD, and then in the distal LAD another 70% disease, and diagonal has a 80% disease, but moderate size and no involvement of the bifurcation. Patient has a normal LV, and then this is an RCA, again moderate disease in the proximal, but mid to distal area, again 80 to 95% segmental, more than 20 millimeter lesion, and significant disease of the small size PDA.
Therefore, clearly multiple 6 lesions, and syntax score actually calculated. If we can go back to the slides, 22, although it is just at that border where 23 and above, our recommendation is coronary artery bypass surgery based on the data, and these are the individual component of the syntax, makes it to 22. I think partly is because there is not a bifurcation lesion and it's not a proximal LAD, otherwise it would have been so that we spoke to the family that we should recommend a multi-vessel PCI, and patient agreed, and now patient is on the table because angiogram was done just yesterday. So in terms of the appropriateness, 3-vessel disease, not on maximum medical therapy, but class 3 angina, or even you take it for a high risk scan, it's appropriate all the way. And the question basically would be that what you do first. Knowing this case as shown, the LAD is a more complex lesion, we'll try the LAD first, and then we'll try the circumflex, whether can do RC at the same time. Patient has the normal creatinine, so that they even gave a small amount of dye yesterday of 22 cc's for do the angiogram. This morning creatinine still remain okay.
So your theme, Samin, is going to be as complete a revascularization as you can do today?
Well, I would say that's basically is that now knowing this LED is complex, is calcific, while I go through in next 10 minutes on the two important themes. One is a lot of issues coming with the genotype, people asking about genetic testing because in the media and so on, recent publication of the GIFT study, and issue about the complete versus incomplete once you decide for the coronary revascularization. Now, you want to make it a point before I go on to the anything special you want to say about the LED?
Knowing that it's a long and before the lesion, if you see there is some tortuosity with the heavy calcium just at the level of the lesion. So I would say I think rotational atherectomy is probably appropriate here for a good stent expansion. And the question always comes, what's the burr to size ratio here? Ideally, it would be 1.75 because of the long lesion and the tortuosity just before the lesion. We have actually downsized the burr to 1.5. And how are we going to wire this is the same. I think we will go with the fine cross, we use our usual wire and then change to rotawire and do a 1.5 burr. Then since it is not bifurcation, we may just have to balloon of the diagonal also. About the distal LED, we can just put a direct stent in the distal LED.
Sounds a very prudent strategy, Anu, and I was going to ask you the question about downsizing, which you have answered already regarding the proximal LED.
Okay, therefore now let me just take you through, and we actually for the genotype testing is a very complex field. I will provide some data, but we actually have we call it the genotype guru at Mount Sinai. Actually, there are two of them. One is on vacation, Joe Sweeney, and second is Man Bauer. He's our interventional attending and will provide some of the data which have been done at Sinai. So basically, first point is that what about this on treatment platelet reactivity, and that is what we call OTR, the on treatment platelet reactivity, OTR or OTPR, and how does it tie with the genotype testing. Now basically issue remains that like anything else in our medicine, that there is always a sweet spot, and if you go to one extreme versus other, you pay the price. If you have a lower platelet inhibition, 10-20%, what you do, you actually cause more thrombosis. If you have a higher platelet inhibition, or you can call it a patient have a lower platelet reactivity, that basically means those patients will have a higher bleeding. If you have higher platelet reactivity, those patients will have higher MACE event, and that has been shown by many studies, so that this sweet spot. Now where it is, it seems to be that PRU, which is a simple way to measure, verify assay, that somewhere between 208 to 230. If you go more than that, you have a higher ischemic complication, and if you are less than 180, you start having more bleeding. And of course, in between 180 to 230, in my opinion, is the right sweet spot of the PRU testing, which is our that is what we are looking for. So therefore, the issue is the P2Y12 receptor is at the center stage of this whole phenomena, because that mediate through the ADP, the platelet aggregation, inflammation, and subsequent thrombosis. Now there are various methods of simplest being the P2Y12 verify assay of Acumetrics. Then there is a light transmission ergometry, and of course VASP stimulation, and then there are many other, the platelet works and so, which were shown in popular study. So key is, from interventionalist point of view, we need the data to change our therapy right there, and that is the verify assay. And there are various cutoff of various of these testings I have put into this slide, basic, but the message is very clear, that if you have a high on treatment platelet reactivity, you have a higher MACE rate consistently shown across the board. Now, why you have high platelet reactivity? Very simple, could be that you are not taking the medicine. But clearly the more important is that there is a genetic polymorphism and drug-drug interaction. And focus today will be our more of a genetic polymorphism, that how the gene plays into it. We all know very well the variation of the Clopidogrel reactivity on multiple cases, and clearly because of the effect the gene have on various the pathway of the conversion of a Clopidogrel from the prodrug to the active drug, and of the various genes, the 2C19 has been at the center stage, although there are ABC gene, A1, B1 and others, many others, but key is the most of the data we have in the literature is about the 2C19 gene. Now, this comes very early from the Triton trial, that if, let's say you have a carrier of 2C19 versus non-carrier, that if you can see here, that if you have a carrier, that you have a higher MACE rate at follow-up and stent thrombosis compared to non-carrier if you use a Clopidogrel. Now, within the Triton as well as in the Plato, by using the newer agent, which is the Prasugrel in the Triton and the Ticagrelor in the Plato, you can see that these newer agents eliminate the issue about the carriers. So that whether carrier or non-carrier, your event rate is identical. So that while Clopidogrel is affected by the gene, that clearly seems to be the newer agent are not affected by the genotype. So the question comes that if you use a new agent, does it even make any sense to do a genotyping? What do you say? Now I'll ask Dr. our expert Usman Babar about this, that if you're using the Ticagrelor or Prasugrel, should you be even testing it?
Yes, well, thank you, Dr. Sharma. I think the available evidence today.
1 second,
there's
let's,
two.
Let's get your volume.
What's? Can you hear me?
Volume.
Hello.
Osman, just a little technical glitch with the volume.
Okay.
Get that sorted out in a moment. Samin, thank you for asking Osman exactly the right question. I'm sure the viewers would be keen to know that. Osman.
Miracle 3 ready.
Hello.
Osman, go ahead.
Yes. Okay. Well, thank you, Dr. Sharma, for giving me a chance to come here and speak. I think the evidence to date, there are 2 points that really come out from all of the data. One is that the events that we're trying to reduce continue to occur at lower and lower frequencies. The most feared event in particular is stent thrombosis, and with evolving stent technology and adjunctive pharmacology, this event is such a low rate, one must question the economic and financial logic behind testing a whole group of people for this. And the second point is that the rationale behind using more potent antiplatelet agents are based on clinical indications, as in Triton or Plato, such as presentation with ACS or positive biomarkers. So while we do see these interesting associations, whether or not there's a benefit in reducing events through guided testing, I think is very much unknown at this point.
And I think that's basically one of the very important message that why you need to worry about using a Clopidogrel, but at the same time, we also know that this is not going away. You say, well, we can change it, but clearly now the Clopidogrel becoming generic, and the whole America is generic drugs. So we're getting so much pressure from the companies with the insurance carriers to switch patient to Clopidogrel, and that to generic, and we know generic potency is only 85%, and so it will become more and more important issue in the years to come. So I'll continue. Now the second issue comes that what if you give a high doses? It turns out to be that if you have the homozygous, which is a red, even if you give a large dose, loading dose or maintenance dose, you really cannot reach your adequate platelet inhibition of that remains low. So that has been very clear that you know what, that what if we can start giving a double doses of the generic Clopidogrel, but that may not be the answer, because those are the cases will not be completely get into the overall your effectiveness even if you give a double dose. Now we also know that from the Gravitas trial that there is, once you get to particularly 208, that associated with a higher event rate, that if you have a more than 208 versus less than 208, the p-value was significant. And the question comes, this is actually a very interesting paper, just came, nothing to do with the gene, but I felt that it's in the this context, that Ticagrelor versus Prasugrel platelet reactivity, and it turns out to be in this study, small study of 22 plus cases, that has shown basically that the Ticagrelor has achieved better or lower platelet inhibition or higher platelet inhibition compared to Prasugrel. And this was a patient's own case control study. After 2 weeks, patients were switched, and you can see consistently that you receive the lower PRU in the Ticagrelor group compared to the Prasugrel group. So it's a very, very interesting observation which we have, and overall. So therefore, what we did also, and this is actually my other expert, which is Joe Sweeney, presented the data in ACC of 100+ cases in a complex, those who were taking Clopidogrel and able to do testings, and the results of the genetic testings available within less than 24 hours, so that we could change the therapy if needed in these patients, and the data basically came out as such. And that is that homozygous state is present in 4%, and heterozygous in about 38%, and means normal, the non-carrier, in about 58%. And that also correlated with the PRUs, that clearly that you have higher PRU in a homozygous, which is 256 mean, and 208 and 218 in the heterozygous and the non-carrier, and that was not different. So clearly, although the event rate, the second part of the whole equation, the event rate was not different in this small study group. But just to say that yes, heterozygous is associated with higher, the higher PRU, whether it really in a small series will translate into a MACE rate, we do not know, but there are other data to support this. Now then, this is a major paper which came out in JACC last week, GIFT study, which is a sub-study of the Gravitas trial. Basically what they did is, all patients were tested for various types of genotype, and found basically that only which really made sense and correlated with outcomes and aggregation was the 2C19. And basically, if you can see here, that those who were basically, that if you are homozygous, you can see that is associated with the lower efficacy, that basically means had a higher PRU. Cutoff was 230, although this was, even when they went to 208, it remained the same. So whether it was time 0, 30 days or 6 months, that it is the heterozygous associated with the higher platelet PRU units. And same here, it's a very interesting observation, and that is that if you are basically the heterozygous, and you can see here, even in the high platelet reactivity, in a heterozygous group, in our patients who got the double dose and not the standard dose, in the double dose, that if which is the third in that screen, that basically in the diamond shape, that does not make any difference. So what basically tells you that if you have the heterozygous, that you basically even giving a double dose of Clopidogrel did not make a difference. So basically it just tells you that therefore if you have tested and the patients are very high PRU, if you have a low PRU, none of the cases had a heterozygous. So basically message understanding here was that if the platelet reactivity can be detected by PRU, verify assay now, and if your assay is high, that even non-carrier, I mean in the heterozygous, which is the both alleles, that giving a double dose did not make any difference, and this actually is translated into the outcome at a follow-up. So basically the message is that you can either do a genetic testing or you can do a PRU. If your PRU is lower, you probably don't need genetic testing. But if you have done the genetic testing, the issue will come that by giving a double dose may not be the answer. And therefore, in this study, that only the carrier of 2 reduced function allele, so that means the homozygous, was associated with higher 6-month MACE, and versus either you have 1 or no carrier, and p-value was 0.03 with odd ratio of 1.58. So very, very important issue which we noted in this study. So that basically the conclusion of the study was a little modified in the sense that the platelet activity really makes a very big difference in many of these patients. Now, and then I'll come down to here now, that how do we should be testing, and so, and actually a lot of work has been done by Usman, and he'll just take us to the Mount Sinai data.
Yes, thank you, Dr. Sharma. So this was essentially a project that we all did here at the cath lab over the last year or so. We took about 400 patients prospectively who were Clopidogrel naive, underwent PCI, use a Verify Now assay to determine their PRU value at a mean of 10 hours after 600 Clopidogrel load. We categorize them into various CYP2C19 genotypes. And as Dr. Sharma just showed, with the reduced care loss of function of alleles, those are the poor metabolizers. In our overall population, approximately 26% met that. And we have a very heterogeneous, racially heterogeneous population here. You can see Caucasians, about 22% were poor metabolizers, meaning they were too reduced or loss of function alleles. African Americans, about 23%. Hispanics at 29%, but interestingly, in our South Asian population, approximately 41%. And on the next slide, you can actually see that actually translated into differences in high residual platelet reactivity. In the overall population, about 50% had PRU above 230. I'm sorry, Caucasians 50, African American 48, Hispanics 54, but South Asians at 68%. So in our own racially diverse population, we're seeing similar data to what others are reporting in different settings.
Yeah. Now, therefore, then question comes, how do we incorporate? Now, if we can, one of my, Pablo, come here, get this kit, bring this one, and can we have the camera focus on this kit? Now, and this actually now has become clinically available, and that is one of the new company actually had come with a buccal smear. So either you can send the blood test or you just do a buccal smear and you get the data. You know, it still takes about 3 to 4 days, but it's the CGAAP, it's transgenomic, the company basically make it available, and apparently this is in a selected cases it is also approved and reimbursed by the Medicare and major insurance carrier, because it can make a major difference in those patients. So therefore this is available. And now Usman, any comment on it? So this new buccal smear genotype testing available now?
Yeah, I think it's just what we were saying, Dr. Sharma. I think as the costs of testing go down, and as more data becomes available, the key thing is going to be identifying, as Dr. Price was in his studies, which patients are the appropriate ones to really undergo these testing. And as we learn more and the technology continues to mature, I think eventually we may have some type of a risk score algorithm to choose the ideal patients to A, undergo testing, and B, in whom we should guide therapy based on that testing.
But by your experience, is there any difference if we do a blood genotyping versus the buccal smear?
As far as my knowledge of these tests, not to date, not that I'm aware of.
So therefore, I think it's a very simple way. So anybody can do it, and you don't have to be go to any refined or ultra lab, and very easy to send. So that this is what we'll be doing. And there are a lot of work going on with this platelet reactivity. One of them is Arctic trial, which is going to modify your use the inhibition and change your therapy and see the overall results. Now, where is the FDA? Remember, FDA said the warning for the Clopidogrel that there are cases that may be non-responder, poor metabolizer. So that you need to be very careful, and therefore they actually made it that there are tests available to determine a patient is that whether patient has CYP 2C19 status. So genetic testing is indicated in selected patients. Now, where is the ACC? ACC is very simple. That what they have done basically is that platelet reactivity testing to determine platelet inhibitory response in patients in acute coronary syndrome or after ACS and PCI on thienopyridine therapy may be considered if results of the testing may alter management, which is class 2B with a level of evidence B. And of course, genotyping of the 2C19 functional allele seems to be the most important being. So there are some recommendation, and same actually the clinical practice guidelines recommendation from David Holmes was that maybe in selected cases you can use it, although if you have an inhibition, really if your inhibition is good, probably genetic testing will be of a lesser value. And that's basically the overall message from my side, is that if you have a good inhibition, and that too is that simple that you verify assay now, take $20 and you can test it. Yep. So that maybe that is good enough. You don't need to do any fancy test. Completely agree. In a high risk cases, you cannot test it because there's some interaction. You are given 2B3A inhibitor, patients in an acute MI setting, patients anemic, very high platelet count, maybe in those cases recurrent events, and you don't want to switch it to a Clopidogrel because of issue about you want to continue Clopidogrel, don't want to go to more the newer agents, that maybe in those cases we can recommend genetic testing.
Yes.
You want to make a last line on this
No, I think I completely agree with your statement, and that is, as I said, which are the one patients. In the low PRU patients, it does seem probably we're not going to get anything beneficial. And really those in whom will have any benefit are those at the highest thrombotic risk, such as acute syndromes or high-risk patients with age and so on. So it'll be some combination of clinical factors that will help us decide who should get tested and what to do with testing afterwards.
Now, among the various ethnic, the reports are coming.
Yeah.
Which, in your opinion, which ethnicity is associated with highest incidence of heterozygous 2C19?
So I think right now,
homozygous, sorry.
So I think right now the East Asian populations, where I'm talking about Chinese, Korean, Japanese, East Asian population, I think have been the most extensively phenotyped and genotyped with respect to CYP2C19 loss of function alleles, and we do have a lot of data on that. I think there are emerging reports coming from the entire Indian subcontinent, of which, of course, is very growing and has a lot of cardiovascular morbidity. So there is a lot of emerging interest, which is one of our cath lab's interest. So as of right now, I would say East Asian ethnicity is the one that has really been linked with the highest association with the loss of function.
Osman, before we leave you, let you go, since you are the resident platelet expert at the moment, if this was, if your father is undergoing a PCI, what agent would you use?
Yeah, very good point. That question is that would you go as just in a stable patient? I think acute coronary syndrome we understand. STEMI patients, we understand you need to go to a newer ADP receptor blockers because both have shown to decrease MACE and even decrease mortality with a Ticagrelor. But stable patients, complex, diabetic, and so that should you be using some different agent, right? That's basically the question is. And like in this particular case, I can tell you that we loaded this patient last night with the torvastatin 80 milligram and 600 milligram of Clopidogrel, and we tested PRU, and this patient's PRU is 205. So that it worked. So that clearly you don't need to do a genetic testing in particular question. But if you want to answer Sameer's question that what agent, what is your preference overall in a stable patient?
Yeah, I think in a stable patient with straightforward lesions, type A, simple type B lesions, and mid to distal segments of the coronary tree, I'm not sure we're going to gain anything. Perhaps in those patients, as Dr. Sharma mentioned, diabetic, high risk, recurrent ISR, probably prox LAD or left main, where even the guidelines indicate there may be a role for platelet function testing, or where stent thrombosis could be fatal. I think one could make a reasonable argument based on the data that perhaps we should test those patients for more potent platelet inhibition. But I think that's reserved for select patients, because other than that, I'm not sure we have the strong evidence base on which to guide therapy.
But at least now we have very simple tool and kit to test it. So that's a very simple, because this they comes with a cartridge and the shipping label, so that you just have to ship it and you get the data, and insurances are directly billed.
How quickly are you able to get the results?
Yeah, actually it takes about 3 days. So that including the mailing time, and they take 48 to 72 hours for the testing. So that you send it on Monday, you'll get the results by Friday.
And the serum testing result, how long does that take?
We can't hear what he's talking.
Yeah, the serum testing probably will be the same way also, right? I mean.
Yes, several days. With the serum testing, you have to extract the DNA and then do targeted DNA probes for the genotype. So it does take some time.
And only selected labs can do that.
Yes,
not everybody is ready to do that. All right. So now we go to a second point. That is the complete versus incompleteness of coronary revascularization. Just to update it, we actually have a little minor procedural setback here. That LED we're trying to wire has a dissection, so that patient is fine. But in these kind of cases, Anu is just stabilizing the patient, putting a balloon pump, and will continue in next few minutes, come back and go through our intervention. Now, so that I'll take you through quickly on this issue of the complete versus incompleteness of coronary revascularization. And I say very simple, that clearly that part of that, anytime when we try to, in this day and age, more complex cases we are encountering, and they are undergoing PCI. And now, all of a sudden, we are being compared against coronary artery bypass surgery. And of course, part of that we always knew that even with the DES, you'll have a higher revascularization. But then, We also know multiple revascularization, multiple at follow-up, they may have more myocardial infarction, some cases stent thrombosis. So that question becomes that if you're deciding PCI, even if not a STEMI patient may be a different issue, exclude that patient with acute coronary syndrome is STEMI. But in the stable patient, it makes sense that you need to do a complete revascularization. Now this actually, I'll show you about 4 data to support, and the latest one of the residual syntax score published in JACC. This is the very early, we published from the New York State in the era of BMS, and these patients were followed for 2 years. And basically you can see complete versus incomplete, one vessel or more than one vessel is the CTO, you have an odd ratio of 2.7. There was incremental when you go from one vessel incomplete to a 2 vessel and so, and with the CTO gets further. Now, then we publish the data on the DES. He said, well, maybe the DES will change. Exactly remain the same. You can see here, mortality, percent-wise odd ratios similar to what was for the BMS. Same data, that one was for about 2.5 to 3 years. This is for 18 months. We also know when we do revascularization that almost 30+% of the time we leave major vessel untouched and no revascularization. So that a complete revascularization we achieve maybe in 30-35% of cases. Repeated studies have shown it, although in the syntax trial, because they forced it, then complete revascularization occurred in about 62% of cases. Still, lot of we leave it, many of them are CTO and so. Therefore, concept of the complete revascularization is very important. This one was the mortality, then we have mortality in MI. Same message that if you leave incomplete, you have a higher event rate. Now, we just published last month in the data in the in the circulation cardiovascular intervention and basically BMS 8-year follow-up. Same message that whether you are complete versus incomplete on the left side, and if you have one vessel incomplete or 2 vessel, multi-vessel incomplete, clearly lower mortality with a complete revascularization versus one vessel incomplete or more than one vessel. Similar data now we have 5-year DES that has been submitted for circulation for review. These are the data from the New York State database. Now syntax clearly gives you that at least what is complete and non-complete will be simplest way. You count all the lesions, like this case we did, 22 Harris syntax score. So now whether you have taken care of all 22 or you did 20 and you left 2 as a unrevascularized. So that becomes the part of the residual syntax score, and that is what I am going to speak about. Basically we knew that higher the syntax score with the PCI, which in the blue, you had a higher event rate, but not with the cabbage. And of course we have the data of the score wise, your low score clearly that as good as with the PCI and cabbage. Intermediate we start losing to at 4 years to the cabbage with the death as well as MI and so, and of course revascularization we knew all the time. And the lastly that if you are high risk, clearly a higher syntax score you have adverse outcome. What is came out very interesting is that what if from the syntax trial, what is the impact of the residual syntax score? And basically was that they divided that whether your residual score was 0, 0 to 2, 2 to 8 or more than 8. And you can see here, this is the 30-day data, and then I'll show you the 1 year. The very simple, that MACE rate was proportionate to your residual syntax score. So that if you did a PCI and you left many of the lesions alone, that you did not do a good job, because those patients will have a statistically higher MACE rate. They actually have the trend towards a lower death rate, and of course you can see with a myocardial infarction and stent, just a trend towards the stent thrombosis. But more important issue remain is that your higher MI and MACE rate, even now you take a 1 year data with the residual syntax score, very clear that you do have higher MI, death rates and MACE, although urgent revascularization is not there. So that basically what it tells you that we as an interventionalist know which vessel need to be taken care and you take care of it, other you can just leave it for a medical management. But point remains is by leaving the residual lesions, you will risk the patient for a follow-up death MI. So that point of the complete revascularization gets as good as from this data. The residual syntax score, if you decided PCI, is a bad news. So that what you need to do, that you need to be a better, once you decided for intervention, that try to open every vessel possible, because strategy are two different. One, Because many people are concerned that you have done a 1 or 2 vessel, now patient is symptomatic but still has a 95% OM. Now you can decide maybe based on the FFR, which we going to hear next week quite a bit on the from the FAME2 trial. But more importantly, that once the decision need to be made for the revascularization, the effort should be try to make it as complete as possible. Maybe leave it in a small vessel. Like if you see the syntax score, that if you are within 2, that's not a problem. Where really starts having when you get the more than 8 and so. So the basically remaining that if you have very small syntax score 2 or 4 because it's small diagonal and OM, not a difference. But you start getting now 8 plus 8, 10, 12. That's where you have risked the patient for a higher mortality and myocardial infarction.
So, I mean, loud and clear message of the implications of the residual syntax score. Back to the patient, how are we doing there?
Okay, well now Anu will give us an update. In last has been a little excitement on this side. Anu, tell us what's the filter wire. Yep. Show. I'll take it. You just show it.
So this exactly, I think you see that how
it was a very calcific angulated lesion.
And this exactly, I think no more wire was making any turn. So we tried the fielder kinetics and was behaving like a total occlusion just at that level. So I did go with the, this was actually, miracle 3 probably, which went subintimal. And since then, I mean, if you see, this is the next picture we have. Here. We've not been able to get it in the lumen of the LED. So that's where we are. The vessel is still open. We have to get into the lumen.
Now we are using a whisper extra support that I have seen many times when you have this the dissections. It works quite well. And we are going to, now what also happened in these kind of cases, because when you are doing a procedure, knowing that it will take a little while, that if you have a major vessel, subtotal like this, in order to have a good, able to do uninterrupted, that it is reasonable, put a balloon pump. Now a patient has a normal ejection fraction, start having a little bit of ST segment depression. So that clearly that you want to protect and able to do your intervention safely. So that this basically now is the patient has a intra-aortic balloon pump. It's what size we put? 34. It's a 34 cc because of the patient's height and so. Less than 5'4". Although patient has no EKG changes, we can show the EKG. They can show the hemodynamics and the EKG there. Patient sleeping okay. We are not asking the patient to wake up. And basically it's just trying to get to the main lumen, and hopefully the balloon pump will help. Even if you are a little bit of subintimal, we also know that as long as you get to the main lumen will be fine. So what you could do is that leave one lumen there, wire, and go side by side. Hopefully that seek into a different plane. The wire going, the fine cross is able to go through. It's
quite easily.
It's still not a guarantee that you are in the true lumen, but still it gives you good confidence.
Some dye? Probably subintimal only still.
Therefore, what I'll do is, let's bring back, leave this wire, and let me just try the other wire side by side. Leave this wire and bring the fine cross into the guide catheter. Yep. See?
Okay, now dye here.
Just wondering if a little more different shape would make a difference.
Any questions so far?
Yes, there has been a question. I just wanted to let you concentrate. A question from the Philippines, first of all, commenting and congratulating us on the affiliation with ACC, and then asking a question that in such cases of multi-vessel disease, what makes you choose to go for the LAD?
Yeah, well, I mean, in this particular case,
very
I would
obvious.
say the decision was simple because LAD had a almost 3 minus flow. So that, and we are seeing it here, that just because of the gravity of the disease, because you know that if you cannot do this vessel, then this patient will require coronary artery bypass surgery. So it's a reasonable that you go with a culprit vessel, and in this patient, the LAD seems to be most complex, and that basically will determine that are we successful percutaneously, or this patient should go for coronary artery bypass surgery.
Another question from Japan this time, seeking to know if for all your patients with STEMI, you've converted to a 600 milligram loading dose. My answer would be yes.
Some die, or we this definitely is in the lumen, but it has to make the turn.
Yeah, therefore basically the wire is hitting kind of brick wall, lot of calcified. We knew about this calcium.
No.
Has a slightly different path there. This could be, no?
Yeah.
Still.
You want to take a picture? You have to take the field, the fine cross back, then only.
Yeah. Okay, take a picture.
Very tough to say.
Yeah.
You want to just pass on the
No.
fine
I think we are in the lumen.
Okay, then put a fine cross further down, and that will be able to open a little bit of channel.
No, probably not. Subintimal. I want to give some dye in the.
No, you don't need to die.
No.
Okay. Yeah, it's very tough. You know, a lot of people will give the injection through the microcatheter. We actually have a lot of some issues there that unless it's really necessary, that there's no other way. Even if required to give a puncture site from other side, that probably is the better way, although now we have no flow.
Only thing is that here you see the septum. You
Yeah.
see that? That's that septum.
You want to give the injection? Huh?
Yeah, what else?
Okay.
Patient is hemodynamically stable,
Yeah, yeah.
of course.
Yeah, patient is fine, but
No,
we know.
Take it out.
You have it. Very little in there.
Looks subintimal there.
Yeah, it looks subintimal.
Why don't you take? Oh, there's no antegrade flow. So then the only
Leave it there
thing
1
is-
second. Yeah, let me come here 1 second.
You want to do with the whisper or?
Yeah, this is the whisper.
Yeah, just giving it more shape.
Yeah.
Do we get the?
Yeah.
I mean, this view has been good enough to see that. I was just wondering if even a RAO caudal or something, but I don't think that's much of our problem.
Yeah, the tough, I mean, you know it here, that it's a, what we do, yeah. Yeah, this one will
Same path,
Yeah,
exactly the
exactly.
same path it took.
Yeah.
No,
now-
you want to take another. Which wire you want?
No, right
Run
now,
through?
you have a run through or, other non-hydrophilic. try to see whether BMW or run through. The torque on this.
And you're going to leave that wire right there.
And leave the wire there.
So almost a semi-parallel.
Yeah, and then if this patient need to go for urgent surgery, they have to give a platelet transfusion because the patient received loading dose and fully inhibited. So many times the patients are on Clopidogrel, as I showed, that requires surgery that you really don't need to wait your regular 5 days, and so that if you can test it and you see that they are not inhibited, your PRU is more than 230, they can go for surgery sooner than later. Now here clearly the run through is not helping us because of
Let me see.
okay, will die now.
There's a slightly different path there.
Yeah, now looks like the patient may have started having some pain.
Don't take it. That is dissection. That
Okay.
is the pad of that run
Okay.
through doing
Yeah.
it.
Okay, just 1 second.
Give some dye. See that?
Okay.
So only other question is,
Yeah.
do we go there and get into the intima with the stiffer wire?
Okay. Yeah. Good. Looks like the patient start having some chest pain now.
Leave it there. Leave it there. Don't go further down.
Uh-huh.
And then get your. Oh, we can't get the fine cross now, right? It's on the other
Yeah.
side.
Yeah. We can give a little more sedation to the patient. Hemodynamically stable.
Let me do one thing. There's something to know.
Why?
Okay.
No.
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 Some dye.
Give me a 2O balloon.
Some dye. I don't know.
Yeah.
How should
We'll see. I mean, again, the wire went in. We just have to see. There are a lot of intimal channels. So what I do usually, I just Fogarty with the balloon, no dilatation, and then try to see how things are. So now this is the 2020 emerge, the new balloon. And if necessary, clean that fine cross. We might get to the apex and do this. Okay, yeah, hold up. Very important. Okay, we can give a little more medicine to the patient. Patient has good blood pressure. And also very important, our nurses are very expert. They will just do things whatever is needed and basically don't keep us now what I'm going to do, 2 things. First, we are going to take a picture now, low mag with a long one, and the secondly, that many times when you have the dissection area, that you may need to leave the balloon to see the dye going distally. Good. Now, why we are?
every
Can we
time
ask the X-ray? Because is it hot? It is limiting the cine for only few seconds.
you get the fine cross and just go down, right?
Huh?
It does that so many times. After a while, it just stops.
I don't know. My gut feeling is we can now put a fine cross here and give an injection through it. Or you want to use a?
So you think you've kind
twin
of
pass.
This is a twin
re-entered
pass.
the.
Yeah.
We can
I
get a
think
twin
with
pass.
Get a twin pass.
I don't want to dilate unless we are sure that we are the
Twin
true
pass.
human.
Both don't have to go.
Little verapamil. No. The is it hot? Because it stops at 4-5 seconds. Cine.
Die? Die. Yes, sir.
So, I mean, in the meantime, one of the viewers has thought out loud that what about using a star kind of a technique using a pilot 150? All sorts of suggestions.
But you want to
Connect the die.
Yeah, no, you're outside,
Yeah.
right?
Yeah. Advance.
This is what? Okay. Yeah, no, I mean, the whole purpose is that you need to be a distal in a true lumen.
Absolutely.
Yeah. To me, it looks like that we are in the true lumen. We just have to prove it. So that what we have, the twin pass, basically it gives you some monorail, and the central lumen will try to inject through it. Now, many times you will not be able to go through it, but we'll try to see as much as possible.
Breath. No deep
If
breath.
not, then you take a fine cross. It will go slowly. Yeah. That should be okay, right?
Die.
Okay, good. Okay, we are injecting and we are seeing it now.
Look to be in the
Total dissection.
no, yeah, either a extensive dissection or
Yeah. Total dissection.
Okay.
What you could do is
Yeah,
balloon
dilate.
stent
Yeah,
as
there.
much as we
So
can.
therefore, what we do now is, I'm still not sure that we are in the dissection, because the way it went so smoothly, we'll dilate with the 2O balloon in that area, and let's see how things are.
right in the
Yeah.
mid portion.
Yeah. Yep. Yep. No, but we did not go with the loop further. We just had the mid area.
This
Although
two-
now patients start having a little bit of ST changes.
Huh?
Yeah, it's a 2 or 20. Hmm?
38. 3 or 38. Prime. Yeah, go.
Dilate here. Promus element.
This 2O will not do
Promus.
anything, I think.
Promus. Go up. 6, 8. 6, 8, 10, 12. We can take a 2.5, 20 also.
Down.
High pressure.
3O.
Yeah, 3O. Okay, 3O. Yeah.
Go up here.
Yeah. Quantum apex and so.
Go.
Yeah. Yeah. Go. Yeah. We have it. We opened it originally. 6, 8, 10, 12, 14.
Down. Okay. Send back.
What do you think, Anu?
It's very tough to say.
Yeah, very difficult.
Go up here.
Okay. Go on.
Down.
You want to post dilate first?
Where? Proximal.
Proximally.
Okay.
Okay. Before putting a stent, because I don't think we should put a stent.
If we know it is
Yeah.
dissection.
Yeah. If it is dissection and we are in the true lumen distally, then maybe. But I am still not only 90% sure that distally we are in the true lumen. The way the wire has gone. This is the 3O.
And if it is distally in the true lumen, you think you re-entered the
Yeah. No, I definitely,
some place.
that we went through the subintimal area.
Right, and then,
same antegrade star, and then got to the true lumen. But question is, how
are
could
we
we
now?
be sure? Because that's our injection through the catheter did not help.
The waist
14.
means your luminal there.
Yeah. Waist point, we have to do a little proximal first.
Good.
Yeah, guide.
Good. Okay. EKG is good. Go up here.
Go a little distant.
Go up.
Yeah.
Okay, good. Down.
The 3O balloon.
Yeah, this is the 3O 20 quantum apex.
There's a question from the Dominican Republic by Dr. Aramis Gomez wondering how long does it take for your heart team to get this kind of a patient to surgery?
Well, I mean, again, we are just going to make a call. If we cannot establish our antegrade flow, then the patient should go for surgery, and that should be right away.
So that flow is there.
Yeah.
I think we just stent it.
Yeah. So I
And
think
then,
I think that's the all dissected channel. The means means that area is dissections, and we should just put a 3O38 promus and see. Yeah.
A
Go
long
ahead.
stent covering the mid segment.
Don't send the patient for surgery. Don't send the patient for surgery. Yeah, we can get the, I think, there.
Yeah. And you get a knife right ready also in one of them. Yeah. Yeah, just wait, taking a little time.
Go up here again. High pressure.
Right.
There.
18. Yep.
20. That thing. Okay, good. Down.
And because run through went so smoothly side by side, it's hard to say because subintimal it does not go. Let's pull the wire a little bit. Yeah. While our hydrophilic wires can go, but usually this does not. Are you okay? We more dilate.
Go here.
Yeah. Yeah. This is the case where we are not doing the rota, so that even advancing the stent will be a challenge in this calcific angulated LED.
Okay, down. Show the hemodynamics so they know. that
Yeah,
we
it's
are-
still the hemodynamics patient doing fine. There is maybe a 0.5 millimeter ST elevation in lead 1, but rest of the showing the EKG. Right there, good. And good augmented blood pressure, but patient definitely feeling it. There is no question on that point. Your patient has now start having a little bit of chest pain. Now EKG gotten a little better. Make sure the wire is a little distal.
Clearly putting in the timing of placing the balloon pump was quite
Yeah,
optimal,
these
and
tough cases, that's exactly. Otherwise, patient will be jumping up and down.
To
will
me-
be a myocardial infarction. So that you need to be well prepared.
I mean it is not a easy moment even for me to be moderating in a complication, but
Yeah.
I can tell you that as I sit back, I realize that the best teaching value this case could offer is recognizing you have an issue and placing hemodynamic support. And
Good. Go.
Okay.
Yeah.
so I like the positioning of the stent there, and let's see how that does if that tackles any of the subintimal.
Yeah.
disruptions.
While with our Zynes, particularly we don't go beyond 10 or 12 atmosphere. With the promus element, the balloon is less compliant, so that we can go 14 and so 14, 16, and still have a less
The
edge
twin
dissections.
pass
I
ready.
think it was also a good idea to dilate that calcified plaque proximally to enable passage of the stent. Now, the $1 million question is going to be how it looks after this.
Dilate it.
No, no, no. I'm just trying to take it out.
Yep.
Not get out. Okay, ready?
You need to do a little forward,
No, let's see.
Ready?
Take us in it. Okay.
Yeah, let's take a cine. Now, can we
Yeah,
ask
they can
them?
figure it out. This has been going on even in
Fine.
room 3, room 2 when we are doing sweet tours. After a while, I think the fluoro crap, they have changed it. Give me the
No, but I would just do a balloon first.
pistoli. Okay,
Yeah.
get us
Get a
a
balloon, the
2.5.
3O balloon which we have.
Samin, any value to giving a little a touch of nitroprusside through the?
Yeah,
No, I
but
think
we are ready to give nitroprusside through the
Just a touch, yeah.
our
Twin pass.
Yeah. So this distally. What balloon size?
No, this is a
good.
high pressure balloon.
Yeah, that's fine. Low pressure distally. Yeah. I can tell you EKG looking much better. Patient chest pain has decreased. So those are all indirect signs. We have not done the true genetic testing, but indirect based on the platelet aggregation, you can say whether patient will be a responder or not, or as a homozygous versus heterozygous carrier.
So you're just trying to establish whether
just that this balloon flow, low pressure, I'm good for 2 atmosphere beyond the stent, and twin pass with the nitride attached.
What happened now? Can you take a picture?
Yeah, let's try. Okay, X-ray, our X-ray guys, they are okay. Can we take a picture now? Okay, we'll do a fluoro. Okay, good. Yeah.
and that is
Okay.
precisely
We're just doing a fluoro. No, that's okay because fluoro save can also happen.
Yes.
They were just going to show that later on.
Good.
You have got
We
good
a nice
flow there, and
I think we just have to put a stent here.
distally, no?
Yeah,
Yep.
that's where the
Fluorescent.
lesion was.
Yeah,
That
yeah,
could be giving trouble also.
Yeah.
Look,
3 or
also
maybe too big.
We can go
Yeah.
to a smaller one. 2.75 Promus element.
No,
What
2.5,
is-
2.5, 2.5,
Samin, any value
2.5.
of
32.
IC abscessimag here?
Yeah, now if we are thinking that patient not going for surgery, absolutely.
Yes.
Order the abscessimab bolus.
No.
Yeah.
Please, you're going to leave the balloon pump. The guy
Yeah.
will
No, no,
bleed.
but we
Asian
give
cannot-
intracoronary.
No,
Yeah.
please. No.
Yeah.
What is that? We can put a 2.5.
Can we play
32
now?
only you have? 38?
So Anu, your concern there is that you've had a patient with the balloon pump, and if things can be stabilized without
Yeah, I don't want to
2B3A,
give.
you would,
I would not
it's-
want to give.
So
The
worthy-
reason is, remember our groin access was done in an emergency, almost emergency setting, that they could bleed.
It's a worthy.
As long as if there is a good flow and we know the antegrade flow is good, he has no EKG changes. We are going to leave a balloon pump. He's already on platelets. I think I would be very reluctant to give a Riopro.
It's
We want to put a 38. Just cover the whole thing.
But 2.75.
Too
Okay,
big.
2.5.
Distal is
Okay,
not
give a
big.
2.5 38. That's fine.
If you want to be post dilate.
Yep.
Little MI will be okay. But
and the patient has been on bivalirudin as monotherapy.
yeah, he has been with the ACT of 3, 14.
And the key is that good platelet inhibition, which we have, but we'll still, I'm actually overall 2B3A used in our lab is in about teens now. And of the teens, if you take those 15-16% as 100, I'm still the biggest user.
90%.
Well, 90, I don't know whether 70 for sure. And those basically, but 2 boluses of eptofibetide.
I think Samin that purely illustrates even how in a highly specialized institution like yours, 2 expert individuals can have a slightly divergent approach, makes it even nice and balanced. I was amazed today in one of your slides which you were showing about the platelet function and the balance between safety and thrombosis.
Yeah.
Those slides almost looked like the bivalirudin slides where it fit into the exact sweet spot.
Absolutely. Yep.
Don't go too crazy there.
So this is another long 38 millimeter stent.
This is 2.5, 38 Promus element.
I thought you were going in for a 275. You decided to undersize further.
Yeah.
Distally is not a big vessel.
Yeah, that's true.
And then that's actually still okay because once you need to post dilate, we have a 3.0 as well as 2.75 balloon. We can have a 20 millimeter. Yeah.
I can clearly tell you
Ready
one of the agents I would still put down here is nitroprusside. Should you have?
We are going to do it now. We have twin pass ready with the nitroprusside. This overlap area about 14 atmosphere.
Right. And the patient continues to have no ST segment elevation, hemodynamically stable.
Yes.
Okay.
And come back in the guide. No, take this out anyway. Yeah.
Let's see if the flow is good.
Yep.
We should be just giving some. Good. Nice.
Good. You want to give some?
No,
Nipride.
vasodilators.
Yeah, give the nipride.
No, they become hypotensive, tachycardic.
Give one
some
nipride
verapamil.
only.
Verapamil is better.
And now usually nipride 50 to 100, we know it does cause a little hypotension, which is okay.
I counter it if there is profound hypotension with the bolus of
You're going to give some
neosynephrine
verapamil also?
Yep.
Give some verapamil. And give a twin pass through the twin pass.
No, but
and just if our viewers have not noticed, not only did we have a patient with the angiographic complication, but also the fluoro decides to
Shut off.
shut off at exactly the right case. So,
yep. Yeah, and this just tells and patient is sleeping very nicely. Right now, because of the nipride, pressure will go down, which is expected. Which is nothing wrong in that. But you need to be just careful. Give, if necessary, give a neosynephrine. The no ST elevation. Patient is not moaning now. I'm outside. Yep. If we see a good flow, then I think we can call quit for the day, and rest we'll just decide later.
yes, that's absolutely prudent strategy. Let's see how.
2 of neo.
You're out, but I get EKG changes when I'm flushing.
Wash it, yeah. Good. Okay.
I think going back to the case, how else we could have handled this? If you go back to the picture here.
Anu, before that, you think you went subintimal just about there?
No, see if you see here, right? This picture you can see right now, it just tells you how the vessel is traversing. I'm in the lumen, but if you see the calcium, how the calcium of the vessel looks like, and then if I go back to the angiogram,
Yeah, this is it. You see it there.
there is a lumen there, and because of that calcium and the angle, I think
It redirected.
the wire,
It
you
gets
just cannot
redirected
get the
into
wire
subintimally.
to
Yeah.
go through that lumen. Is that, or it is just total occlusion?
I think it was just a very calcific, and see that a wire went in. And
here-
these kind of cases you should not be trying with a rotowire directly.
Yeah.
That is what we did. Yeah.
So we tried all the soft tip wires, which is Fielder, Whisper, and even the kinetics. So then I thought maybe to give me a little push, go with the Miracle 3 wire. But it went through the lesion, but when it reached the vessel itself, it went subintimal. If you can see that right here.
Very intriguing question, Samin. That now that the patient is hemodynamic stable, I'm going to read you exactly as the question has been sent to me. If the hemodynamics permits, can we do an IVUS to confirm intraluminal placement of the stents?
Okay. That's well. I mean,
Angiographically, if you see distal, LAD filling.
if there is a doubt, yes. But let's see. Let us see with a picture, and then we'll decide. Again, everyone's training, everyone's teaching.
No, I see no reason.
Again, yesterday we had no ostium in a CTO, no blunt stump, and the question was, should we do the IVUS to see where to puncture? I said, no problem. We have the angiographic IVUS.
I am more concerned. I think you need to put in one more proximal stent there.
The proximal we might have to do. That's why I did this picture, and that we can do later. But key is here. STs are good. Show the hemodynamics once again. Yep. And patient sleeping nicely. My nurses have done a tremendous job keeping the patient cool, calm, collected while we were struggling with this. Patient sleeping well, good blood pressure, and look at this one.
You
don't
see
need
the
any IVUS
mustache?
here.
You see the mustache of the apical LAD.
All the septals, diagonals, nice, no slow flow, significant improvement.
I don't think you need a proximal LAD stent.
Yeah.
So
we don't want to put more stents if we can avoid the proximal.
No,
Let's take a nice picture.
It's acceptable strategy. Anu, take me through how you will manage this patient. Where does the patient go from here? When do you decide about the balloon pump?
Setting, since we put the 2 long stents,
Right.
and we had some residual dissection, I would not want to give 2B3A.
Okay.
So I think we will leave the balloon pump for this guy overnight. So he will go to CCU.
You need a stent proximally.
Yeah, proximally there is
We
dissection.
definitely will just put a one stent there. Yeah, as you saw it in cranial view.
Yeah, I now how much would you think getting the wire through there should be all right?
Yeah.
I mean, it's not. Yeah, I was concerned here in this view before.
Well, let me put this way, that once we have gone through that dissected
Right,
human,
chances are you should be able to, no doubt. Now, one of the questions I have here for you, at this stage, would you use a new wire?
well, actually, I try to use the same wire because the wire probably has the memory.
Okay.
I believe in that.
So, what wire do you have
This is
there?
the run-through wire.
Okay.
Yeah, now clearly the tip might have been a little deformed.
Yeah, that.
You have, if you have another filter wire or whichever way.
I think the
why you
run-through is
pick-
good.
Yeah. Or another run-through wire. The key is that same until you get to the, now once we get to the true lumen, and I think we can stop our webcast now, but key is that after we get to the lumen, so they're just putting a issue with another stent, or we want to continue, that will be your choice.
My choice here would be to continue. It's not. I remember this being the second incidence in. Okay, here we go. We look to be exactly right, and
But which stent? Let's leave it there.
let's put in.
Just
My
make
guess
sure we
would
are
be a
okay.
3518.
Good. Huh?
A 3518.
No, 18 or 20,
18
no?
or 20. Yeah. And
You have to come up to that. So you're stenting
It's-
across the diagonal.
Yeah, right now we are going to across the diagonal. No question on that point. Yes.
so much
Okay.
hard work salvaging the patient. Let's.
Okay, take a picture so we decide length.
It's a beautiful view.
That means come up to the ostium.
Yeah.
No, this is if you're going to put promus.
Yeah.
Do you want to come up to the ostium? Look at that.
That's fine. 20. Yeah.
3520.
Yep.
Anu, any purpose of doing a ACT here?
We could,
Yeah.
although.
Now, but let me just complete it, because that's Anu said on the plan on if would be her patient. Then again, as we said, that there is some variation. What I'll do in this case, that after the case is done, we will do a 12-lead EKG.
Okay.
If this patient has, because patient is not having any chest pain, on the monitor lead there is not ST changes, but at the 12-lead EKG, if there is any ST changes, I definitely will give, I don't know whether I need to give it intracoronary, but I will give a F60 bolus in this case, bolus only, no infusion. And we actually have received the boluses in the lab already.
Okay. Looks
Right now. Good. Right? Yeah.
Pull back a little bit.
Yeah, that's fine.
Too much overlap, no?
Yes, that's I did.
You can pull back a little bit.
Yeah, just a little bit and.
Some back.
No.
Oh, too much now. Wait. Okay, now die.
No, way too much.
Okay. Can you just
That's
no.
okay. This is the good view.
Yeah, I know, but the thing
It
is,
also
see the
convinces
hospital,
me and demonstrates how much more interest there is in when there is
Go.
the series of questions which started coming in once the patient was unstable was quite remarkable. Yeah, there was still a significant waste there, no?
Yes.
So
down.
hopefully this will even improve
I
the
think
flow.
balloon, when we ballooned it,
Yeah. And you'll advance
Dark
that
is
balloon
okay.
and
Yeah, go up. Now another region in this case giving a 2B3A would be if the diagonal has gone.
right.
So now you can go 16. Go to
Going back to the days
Yeah,
of
not really, not
epic
really.
trial and the data from there.
Yep.
in between area.
Yeah, with it, moved it further. We actually have our cardiothoracic colleague, Dr. Phil Subi is here, and looks like that you can go and have your coffee. Thank you.
So let's say if the patient does well, would you send him home and bring him back for the second procedure?
Now in
Okay.
this particular case, any further procedure, in my opinion, is contraindicated.
Right.
Therefore, now you need to let this patient recover and relax. The vessel, which was a type, the TIMI, culprit vessel with a low TIMI flow, we are taken care. Actually, I was so much concerned after the angiogram last night on this particular case that I put him on low dose IV nitro.
Probably
Because
need
of
to go
that-
back to the
yeah,
other view.
I didn't want to give a heparin because we did a manual sheath removal. Okay.
I think
All right. Good.
proximal looks
Okay,
all right,
if-
better flow.
Should
If
we
it is
post
okay
dilate
with-
multiple stents
Yeah. Yep.
or no?
We can, I don't think, because we have post-dilated, went to 16 atmosphere, and we can get to the last part of the slide, and you have trio balloon anyway. You need to post-dilate. You can post-dilate the mid-segment. So if we just take to the take-home message, I know we have gone beyond the limit.
Samin, I think it was worthy taking it beyond.
Yes.
It's an excellent demonstration of how you remain calm in the middle of taking care of such patients. If somebody could show us the hemodynamics one more time before you go, excellent. All right, looks all right there.
Yeah.
Okay,
And-
Samin, what do you have for
And
your
the EKG,
take-home message?
You have the EKG there? Oh, good. You have it there. Good. Now, just to basically sum it up, exactly what we have spoken, and I'll read it. The 2 points we had today: residual platelet reactivity on treatment and the relationship with the gene testing. And second is completeness of coronary revascularization, the PCI arm when you decide PCI. So, first point, the residual platelet reactivity after ADP receptor blockers is modulated by various factors, including the genotype. And high platelet reactivity post PCI is associated with higher MACE. We understood even in the Gravitas trial that you clearly have if you have a residual high activity, you are associated with a higher outcome, MACE rated follow-up. Exact role of routine genotype testing post PCI is not well established, but could be indicated in high risk clinical scenario. As we said, diabetic, MI, high BMI, old age, maybe in those cases you may do it because you may change the therapy. Very simple. But I had to put one more liner, that if you know, documented your platelet reactivity is low, you have done your PRU and it's less than 230 or 208, then clearly the genetic testing does not help. Very important. Second, incomplete revascularization during PCI is associated with adverse short, intermediate 1 to 2 years and long term 5 to 8 years outcome. Clearly it speaks for complete revascularization. So every effort should be made to achieve complete anatomical or physiological FFR guided, which we'll hear more about with the FAME2 trial, that how many lesions they left in the FFR group, revascularization during PCI. And it turns out to be that in a multi-vessel disease, kind of cutoff is the syntax score of about 2. If you have a 2 to 3, you can leave it. Probably has no issues. Once you start getting 5 to 8 and above, then clearly the incomplete revascularization with a residual syntax score in a multi-vessel disease in the PCI arm using the Texas stent which was done in the syntax trial was associated with a bad outcome, particularly of the MI, death and MACE. There was no difference in urgent revascularization or stent thrombosis.
Anu, just to read you a follow-up remark from the Philippines. It was a scary moment there. I'd like to congratulate you for a well done job. I kind of, that expresses, I think, the theme we may be having. Anu, final thoughts from you, and a specific question I have for you. Would you do anything different? Or would you have done anything different in this case?
Here, I think the wire choice, maybe I should have still tried with the floppy wire rather than going with this stiff wire. Usually stiff wire helps, but since it was an angulated, calcific angulated lesion, stiff wire probably was a bad choice.
Well,
it just directs you to a different area, and same thing, since it is a stiff wire, it just caused a dissection and went to some other area. But a more important thing, I think, once we are in the lumen, okay, we caused dissection and we knew that this patient was stable. Even if patient had massive ST elevation because of the LAD close, the fact that there was no ST elevation and he was stable itself tells you this was a chronic subtotal to total vessel, and the patient was used to not having a flow across the LAD, though angiographically it looked that it was such a mega LAD. We saw the dissection and very little hemodynamic changes. So first thing you need to do is have a balloon pump ready, because he already had normal LV function. But once you get into your lumen, I think the key is not start dilating immediately. Make sure you are able to see the distal part of the vessel, which we showed you that you have to inject through some kind, either over the wire catheter or some other catheter. Once you know that, then only you can put dilate and stent. Now distal dissection we have left, nothing to worry. We have the balloon pump. You'll have a good platelet inhibition, and that will take care of it. You will see when he comes back, the LAD will be looking good distally.
Yeah, and I think the other very important take-home message and teaching point here was, once you got into the subintimal, leave the wire there, because anytime you try to put a new wire will go same. So therefore, and then try the non-hydrophilic wire. So that's what I did. Go to a run-through, go to BMW. That's not the first wire of choice. But your stiffer wire, your hydrophilic wire have gone into subintimal with a fielder and whisper. So therefore now you leave it there, and now you try your unconventional, which would not have been a choice, but this type of scenario has worked out many times, that your wire went into subintimal. I'm not talking about total occlusion. Non-total occlusion has created dissection, leave the wire and go with the BMW or run-through. Run-through, we got so good at it, at become a workhorse wire in many of these complex cases.
I think, Anu, you need to be congratulated on handling the very difficult situation with the great maturity and calm. I think your placement of the balloon pump was exquisite. The further handling of the wires, the using of the balloon catheters, the confirmation of the distal flow, and overall, I think viewers would have found a great many lessons which they can take care and learn from this kind of a case. Most of us can have complications, and how to stay calm through it and manage it in a very systematic fashion, as you have shown, I think will be found greatly useful. I'd like to remind the viewers, please follow our companion webcast tomorrow on the peripheral interventions. The next session will be September the 18th. Samin, final thoughts. I'd like to congratulate your entire team for an absolutely outstanding job.
Yeah, I want to, Pablo.
Come everyone.
I mean, you can imagine we physicians, with the help of course, I have my two fellows here. We have Bakhtiar and Jenny, who are well trained, but you have to know, when we are doing handling this kind of cases, we are concentrating on the patient's angiogram here, but we could not do this kind of tough cases without the help of our staff. We have our excellent CVT, who is Pablo, we have Alex, and then we have our nurse Christine and Leonette. They all are so well trained. They know when the things going wrong, what is the next step to do, and they keep doing. One person is ahead and they keep doing what they have to do. Right now, you can see he's actually snoring.
Yeah.
Patient is snoring.
That
And
is
good EKG.
Yeah,
good
EKG
to
And
is
the
know.
captain and nurses did a terrific job, so we continue to, and clearly it was a tough case, but great. Thanks, see everybody next month.
Sameen, good job. Well done, Anu, and we'll see you all next time. Thank you so much.